Everybody. And thank you for joining us for this Cafe Sci. My name is Dan Lavoie, and I'm honored to be your host this evening. Cafe Sci is presented by PPG. Cafe Sci is also supported by the good people like you. Thank you for everyone who donated to support our program. And if you are unable to donate, but would still like to support Cafe Sci, the most helpful thing that you can do is invite your friends to join the audience. Cafe Sci takes place the first Monday of each month, and you can register for next month's speaker at CaymanScienceCenter.org. Before I introduce tonight's speaker, I'd like to remind everyone that there will be a Q&A after the talk. For our on-site audience, please raise your hand and we will bring the microphone to you. Online audience, you can ask questions by using the Q&A button at the bottom of your Zoom window. You can enter your questions at any time during the presentation. Tonight, I'd like to introduce Dr. Emily Earnest, a board-certified clinic specialist of women's health physical therapy. Graduated from the University of Pittsburgh in 2013 with a Bachelor of Science in Rehabilitation Sciences, and in 2018, a Doctor of Physical Therapy. Emily is also a certified lymphedema therapist, a certified strength and conditioning specialist, and a USA Weightlifting Level 2 certified coach. The majority of her clinical practice has been focused on pelvic health and lymphedema physical therapy. She has an extensive experience treating orthopedic concerns and chronic pain. Emily currently works for the VA-VISN for Clinic Research Hub Telepain program as a pelvic health and chronic pain specialist. In her free time, Emily enjoys playing Gaelic football and camogie and writing fantasy novels. I would like to introduce to you all Dr. Emily Earnest.
Thank you so much. Hi, everybody. Hopefully everyone can hear me okay, both in person and online. Thank you all for coming out here on your Monday evening to answer the age-old question of, wait, I have a pelvic floor? And I promise you, by the end of today, you will know that answer and more before we leave here at the end of the night. Again, I wanted to thank everybody here at the Cayman Science Center for inviting me here. Anytime I get the opportunity to talk about pelvic health, I'm always here. So again, can't wait to talk to you all about the pelvic floor and everything else related to it as we go through the lecture tonight. So a quick brief introduction. Again, Dan, thank you for the kind words and the nice introduction there a moment ago. Again, I am a pelvic floor physical therapist. And when you have somebody who is a specialist in pelvic floor, right? This is not someone who just graduates from physical therapy school and just jumps right into the world of pelvic health. This requires extensive education beyond the doctoral degree that you do receive as a physical therapist, mentorship, training, all those sorts of things to get to that level. So again, I've been doing this for basically the entirety of my career at this point. I also play the sports of Gaelic football and camogie. Camogie is like field hockey up in the air, and Gaelic football is like soccer with your hands, both national sports of Ireland. I'm also an avid reader of everything fantasy. I write my own fantasy novels as well, and I also am the co-host of a podcast called Plot Holes and Purrs, where we kind of merge the perspectives of my world as a pelvic health therapist and looking at the fantasy world and the different kind of intimacy scenes and romantic scenes that are very popular in common fantasy novels today. So again, if anyone has any interest in that, great way to learn a little bit more about the pelvic floor through that fantasy lens. And of course, I am a cat mom of not one, but two cats. Who I would be remiss if I did not feature them in this presentation. Benedict likes to hang out in laundry baskets, and then Gregory likes to hang out in shoes. So again, we have many pictures of them, but these are the only two I'll share with you tonight. You can see me in the bottom corner with a stick and looking wildly happy. That's me playing camogie, and then me kicking a ball. That's me playing Gaelic football. It's me with my husband at my Lord of the Rings themed bridal shower, because yes, I am a major nerd if you have not figured that out already, and me with my sisters at my wedding in 2024. So enough about me. Let's dive into the meat and potatoes of everything here. So what is the pelvic floor? And you saw that the title of this presentation was, wait, I have a pelvic floor. And that title was here for a reason. When I started in this specialty of pelvic health, I remember talking to my parents about getting this new kind of education and learning about this special area of physical therapy. And my dad pulls me aside and says, wait, Em, do I have a pelvic floor? And I'm like, yes, Dad, you do. And it's a common misconception that the pelvic floor and pelvic health concerns are only things that are for women, right? If someone has a baby, they have a pelvic floor issue, that's the only person who can have this kind of concern. And that actually is not the case. So let's talk a little bit more about what the pelvic floor is. And you can see here that I have my lovely pelvis. There's a great story behind this. I actually won this pelvis in a raffle. My husband insists that I was the only person who signed up for the raffle. That is why I won the raffle. That is very untrue. It was highly contested after, and now lives in my office. So again, I will fight him till the end of time about that, but that is how I got my pelvis. So very often when we talk about the pelvic floor, people most often think of the Kegel, right, or the Kegel muscles. And again, saying the pelvic floor, saying Kegel, tomato, tomato. It's more or less saying the same thing. And you can see from the pelvis here, and again, this is a female model. This is what I won in the raffle. If anyone knows of other raffles that are giving out male models, please all sign up for that. That would be grand, all right? So you can see here that the pelvic floor muscles take up a lot of real estate. And just to kind of orient yourself to space, if you were to put your hands on the top of your hips, right, like you're feeling sassy, okay, this would be this bony landmark at the top of your hips. You have your pubic bone in the front. You have your sit bones here at the bottom. So if you're going to shift your bum back and forth in your chair, you'd feel your sit bones. And then in the back, you have your sacrum and your tailbone. And you can see this sling of red muscles that goes all the way from the front to the back. If you look at it from the top view, and yes, great model, I can take out the organs, how exciting. You can look at it from the top view, okay? And it's this bowl of muscles that rest at the pelvis. And again, because it takes up a lot of real estate, there's a lot of different jobs, which we will discuss here momentarily. The pelvic floor is made up of different layers, okay? You can see in some of these models that there's this triangle-shaped area of muscles at the front, okay, more superficial. And then if you look deeper underneath the layers of muscles, you'll see another or deeper layers of the pelvic floor. And when you're looking at the structure, or what are these muscles made out of? The pelvic floor is made of skeletal muscles. So just like the muscles that we have in our quads or we have in our biceps, the muscles we go to the gym and train and work out, it's the same kind of muscle fibers in the pelvic floor. And it's comprised of about 70% endurance muscles. Think your distance runner, your marathoner muscles, and about 30% sprinter muscle, your fast twitch muscles, okay? So when we're looking at training the pelvic floor, and I promise you we will dive more into this later on in the presentation, it is not just about squeezing as hard as you can and letting go and repeating that a billion times a day. If you ever told a runner, yeah, just run when you feel like it and show up at race day and do your best, they would run away and find another coach immediately. That wouldn't make any sense. So when we're training the pelvic floor, we need to be just as vigilant and just as mindful about how we're doing that, okay? So again, lots more to follow on this. When we're looking at the movement of muscles, right, and the pelvic floor in particular, so often we think about the pelvic floor only needing to be tight and only needing to be tense, and that being the only important thing of that muscle, okay? I like to describe the movement of the pelvic floor like a trampoline. So I want everyone to visualize walking in their neighborhood, and there's got to be one house that has a trampoline, right? Someone's got a trampoline close by. And you're looking at the trampoline, leaves on it, there's acorns, there's probably some crazy squirrel or maybe an errant groundhog or something running on it, but it's not losing any tension, okay? It's maintaining tension at rest. If someone jumps on it, it's able to elongate. It gives, but it doesn't collapse on the ground, okay? Because if the trampoline was so stretched out and so long that you were just jumping on the ground, that wouldn't be any fun. But if the trampoline was pulled so tight and pulled so taut that you were jumping on it, you're still not going anywhere. That wouldn't be fun either. So the pelvic floor needs to move in that whole range of motion to be optimally functioning. It needs to have tension at rest. It needs to be able to elongate in certain situations. And it also needs to be able to have tension in certain situations. So this brings up another point. I have so many people who I have this conversation with who say, whoa, 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 Emily, you said that my muscles are tight and now you want them to be longer. Does that mean they're going to be weak? Does that mean I'm not going to be able to keep my urine in or have issues with my pelvic floor because of that? No. Think of Olympic gymnast Simone Biles, right? She is super flexible, but also super strong. You don't have to sacrifice one to have the other. So especially in the pelvic floor, we want a pelvic floor that is mobile and a pelvic floor that is coordinated and a pelvic floor that is strong, okay? So different ways we can look at this muscle and different ways we can think about optimizing function. Okay. So I alluded to what are the jobs of the pelvic floor. We know it takes up a lot of real estate. We know just based on where it is in space, it has to have a lot of different tasks that needs to do on a day-to-day basis. And in the pelvic floor world, we like to break this up into the 5 S's, okay? One is support, okay? Keeping all of your organs inside your body where you want your organs to stay, okay? Stability was you're walking and shifting and jumping and skipping and doing all of your day-to-day things, helping to shift weight throughout the pelvis, okay? There's sexual function, dealing with arousal, orgasm, erection, ejaculation, all of those sorts of things. There's a sphincteric function, which is traditionally what people think of with the pelvic floor, keeping your urine and feces in when it needs to stay in and letting everything out when it needs to come out. There's also a sump pump function. Let me tell you, you can't really find an illustrated version of a sump pump, so I had to just put a picture there. So if anyone wants to draw me one, that would be grand. But with the sump pump side of things, it's moving lymphatic fluid and also moving blood throughout the pelvis region, if you will. So 5 S's, 5 functions of the pelvic floor. I always like to bring this up, and I hear this all the time. Doctors told me I need to do core stability, or I want to get back to my core stability. I got to get my core strong. And that brings up the question of what is the core? What does that actually mean? So many people, when they think of the core or core stability, think if I do 1 billion crunches, I will have the strongest core in the world. That's just focusing on one part. That's focusing on the rectus abdominis. The core encompasses so much more than just that muscle group. And you might have figured out by now, the pelvic floor does play a part. So when we're truly talking about the core, we're thinking about this trunk region as a canister, the pelvic floor being the base, okay? The diaphragm, the muscle that contracts and relaxes as you breathe, being the top, the lid, if you will. And then we're looking at the muscles wrapping all the way around your waist, your transverse abdominis, those other stabilizing muscles in the back and the abdomen, kind of wrapping around the side of this canister. And again, it works like a unit. It works like a system. So if they're optimally functioning together, that is going to help in a variety of different situations, from a continence situation, from a back pain situation. So again, so often, and it's frustrating as a physical therapist, but especially as a pelvic floor physical therapist, that so often we just ignore the pelvic floor. We just think about the back muscles. We just think about the abdominal muscles, and we don't look at an essential part of this whole canister and this whole core, right? So anytime you're doing your bird dogs or your dead bugs or your planks or anything of that variety, your pelvic floor is involved to an extent. Now, here's a great question. Do you need to be squeezing your muscles as hard as you can the entire time you're doing those exercises? Let me ask you another question. When I'm walking, do I squeeze my butt cheeks as hard as I can as I'm walking across the stage? The answer is no. So your pelvic floor can be involved without maximally being contracted all the time, okay? And we'll dive more into that. I feel like I say that pretty often. I'm not a great swimmer, but we will dive into things from the informational side of things. But again, you don't need to have a maximum contraction of a muscle in order for it to be optimally functioning. So keep that in mind as we're going through things here. Okay, so you all should have received a party favor coming into the auditorium today, a balloon, a balloon. So yes, I love a good party favor. When I'm in the clinic, I'll give you resistance bands, but today you get a balloon. So this is exciting. So there is a method to my madness, I promise you. This is not for my own entertainment, but for educational reasons. So what I want you to try to do is just blow up the balloon. Okay, so everyone take a second. If you're at home, if you happen to have a balloon, that's fantastic. If not, imagine as if you were doing the task of blowing up a balloon. And as you're doing this, these are the things I want you to think about is, oh my gosh, do I feel like I'm getting dizzy and lightheaded because I'm blowing so hard to try to get this balloon to go? Do I feel my belly muscles move in or move out? Do I feel like this is a really difficult thing for me to do? The kids always like doing the balloons because of said sound that just is made with the balloon, right? But there's a reason why we're looking at the breath and we're looking at the pelvic floor and how all this works together. So as we're breathing, let's talk about the mechanics of how that core works together, okay? Everyone take a big breath in for me and take a big breath out. And do that one more time. Take a nice big breath in and a big breath out. So when we're looking at breathing, we're getting movement of the diaphragm. That's the muscle that slices us in half just underneath the rib cage. So as we inhale, what we want to happen is that the diaphragm contracts, the rib cage expands, okay? The pelvic floor lengthens. So it's this big opening and big filling, okay? And then as we exhale, everything you can recoil. So what do we have to do in order to blow up a balloon? We have to exhale, okay? We have to breathe out. Everything should be drawing in. We should have stability in the abdomen. We should have stability within the pelvic floor. For those of you who struggle to blow up the balloon, begs the question, when you were breathing in, did your rib cage expand? When you're breathing out, did your abdominal muscles draw in? Did your pelvic floor draw in? Did you have that stability that you need in order to stabilize the trunk to send out enough air in order to fill up the balloon? I remember the first time that I did this exercise with my mentor, and I was horrible at blowing up a balloon. I mentioned I've always been horrible at blowing up balloons. And that was why, because I had some dysynergia, some incoordination with my breath and with my abdominal muscles, right? But you can see this breath strategy in a lot of different ways. Think about folks, again, from like the weightlifting perspective. There's a time and a place where you can have a Valsalva and have kind of that stability mechanism. But so often what happens is people do this and they push out and they push down, and then they can leak, right? That means the pressure is not being managed appropriately. So it begs the question, how do we optimize that stability so that we're not having those symptoms as a result? I see some full balloons. If you want to tie them, you're more than welcome. But I want to give everyone 3 seconds to let them all release if you would like to let them go. So 3, 2, 1. Excellent. That was a ton of fun. We can do that later if we'd like. So again, moral of the story, the too long don't read, if you will, is your breath and your pelvic floor and your trunk muscles, your core, all work together, all work as a unit. So if we see dysfunction, we don't want to just zoom in onto one part, but let's take a big step back and look at the whole system. How can we break down the system to optimize function? Okay, so we've talked about a lot of things already. What the pelvic floor is, where the pelvic floor is, what is the job of the pelvic floor? How does the pelvic floor work as a part of a core, or the core, if you will? So let's talk a little bit more specifically about the pelvic floor itself. So how many times, right, you hear someone say, pelvic floor physical therapist, what's the first thing that they yell out? Kegels. Wow, that was a very enthusiastic yell from the audience there of Kegels. So often I hear folks who get referred to me for pelvic floor physical therapy or asking me about pelvic floor physical therapy who are just like, oh, yeah, I mean, I'm just doing my Kegels at the red light. Like, that's just what my doctor told me to do. And it's not working. I'm just going to be like this forever. So many people, and they're resigned to the fact that the red light Kegels didn't work, that they'll never find solutions to their pelvic floor dysfunction. I am here to tell you today that there are better answers than red light Kegels, and we're going to talk about that right now, okay? So Kegels are a part of the program for some folks, depending on your presentation. But again, just like somebody who comes in the clinic for low back pain, if your PT walks up to you, doesn't even look at you, gives you a list of exercises and says, yeah, just get on the table and do those and that'll fix your back pain, run out the door and find a different clinician. Every single physical therapist, doesn't matter what you're being seen for, but especially for the pelvic floor, you need to be evaluated. Your treatment plan should be indicative of what your dysfunction is, right? And we're creating a program based on what we see. So I don't want to demonize Kegels. I don't want to damn Kegels, but there's a time and a place, and there's a way to do them correctly, and there's a way to do them optimally, okay? Squeezing at red lights ain't the move, okay? We've leveled up beyond that. There's a lot better ways that we can do Kegels, and we will discuss that here. Okay, so what is a Kegel? What does that mean? Let's talk through it. So doing a Kegel or doing a pelvic floor muscle contraction, right? It's that engagement of that sling of red muscles that I just showed you earlier on the model here. And I have so many different folks who I see in the clinic, and some folks will come in and say, yep, easy peasy, lemon squeezy, I've got this down pat, I know exactly what we're doing, level me up. And I have some folks who say, oh my God, I have no idea. I don't even know how to say that. Is it Kegel? I have no clue, right? So I see both ends of the spectrum. But I also see some people who come in very confidently and say, oh yeah, I know how to do a Kegel. And this is exactly what they do. And this is no exaggeration. They squeeze everything, okay? They squeeze every single muscle in the body. They cross their legs, they squeeze their butt, they cross their arms, they bend in half, they sing a little song, they do a little jump in the circle, they do everything. They squeeze all the muscles that they have, thinking that that is what they have to do in order to do a Kegel. There are ways to optimize that, okay? And that's what I say. That's a great start, but let's pull back a little bit. So the first things first, okay? As I'm walking around on this stage right now speaking to you all, I'm doing a pelvic floor contraction. I'm letting go of that muscle. You cannot know the wiser, right? It is not a mystical, magical trick. That is called isolation of the muscle. Being able to turn the muscle on and turn the muscle off without anyone from the outside being able to tell. So we're not using compensatory muscles. We're not squeezing our butt cheeks. We're not squeezing our bellies. We're not holding our breath, okay? So that's step number one, okay? Isolation. What are some of the mental cues, right, that we can think about when we're trying to engage the pelvic floor? Me telling you do a Kegel, for some folks, they're like, I have no idea. I need something a little bit more concrete than that. Let's break it up into 3 different sections or areas, if you will, okay? I'm holding up my pelvis at a side view, okay? This is the front of the pelvis. My backhand is right over the sacrum and the tailbone, okay? So let's think about it more from the anterior view, okay? So from this front side, if you will. The most common cue for trying to engage the pelvic floor muscle is as if you are stopping yourself from your peeing, okay? You're peeing, you stop yourself from peeing, that's a Kegel, okay? Please do not practice this on the toilet. That can impair your micturition reflex, that can create other concerns. Trying once or twice in a blue moon is okay, just so you can know, yes, I have that muscle, I feel confident in that, but not something you want to do with regularity, okay? So imagine as if you're stopping yourself from peeing is one way to engage. For my folks with penises, okay, thinking as if you are pulling your penis into your body, tractioning and pulling that up and in, that's another great way you can think about it. All right, looking more from the bottom, okay? I hate this cue more than anything in the world, but this is something that's very common in the world of pelvic health, okay? This cue is as if you are picking up a blueberry with your vagina. Is it practical? No, I realize that. I understand that. But that visual or that mental imagery of that picking up and pulling up and in can be really helpful for folks with vaginas, right? For my folks with testicles, I did not make this up, but thinking about nuts to gut, okay? Pulling testicles up and into the body as if you're tractioning them up and in. Again, are these cues a little bit ridiculous and sound a little bit crazy? Perhaps, right? But thinking of that in your head can be enough to get that muscle to fire the way that we want to. At one of my previous jobs, I actually worked with pediatrics, so little ones, 5 years old, 6 years old. You obviously can't use any of those cues with them. That just won't resonate with them, and it's not appropriate to use with a pediatric population. So what I would tell to them, they all know Pokemon, they all know Pikachu. All right, imagine your Pikachu, you're pulling your tail into your body. You're hiding your tail so no one can see. You can actually feel your pelvic floor. And again, if anyone feels comfortable, you can feel this over your pants or over your shorts or whatnot. If you feel for your tailbone and come just to the side of it, okay, just off the bone, your pelvic floor is right there. So if you're doing a Kegel properly, you'll feel that tension of the pelvic floor muscles. You'll feel that almost as if you're trying to pull your tailbone into your body. That's a great way for folks who are uncomfortable with engaging just in isolation or need a little bit more tactile feedback to be able to feel if, yes, I'm turning on that muscle correctly, okay? So think about pulling in your tail or think about stopping yourself from passing gas, okay? So holy moly, bunch of different ways to think about that. Some of those cues might have resonated more with you. Some of those you might have been like, that is ridiculous. There's no way I'm going to use that as an example. And if that's the case, that's okay, okay? But I imagine more people than not are actually trying to do Kegels right here as we're sitting here talking about it, okay? So what I want you to try to do, this is exactly what I do with patients in evaluations and what I do in the telehealth realm, okay? So everyone's sitting right here in the chair. What I want you to try to do now, just right here and sitting, I won't be able to know the wiser because you're not squeezing your bum, you're not squeezing your belly, you're not holding your breath. I want you to try, and again, I'm just using my hand as an example. I've had people think they have to do this to do a Kegel. You don't, okay? This is just a visual. This is the pelvic floor muscle relaxed. This is the pelvic floor muscle contracted. This is the pelvic floor muscle relaxed. I want you to try to squeeze and hold that muscle and see if you can hold it for 5 consecutive seconds, okay? And then let go. And what we're testing for here, can you hold it for 5 consecutive seconds without it puttering out or running out of steam. If it stops at 2 to 3 seconds, that means you have about a 2 to 3 second endurance, okay? But if you can hold it for 5 and let go, that means perhaps we can test to see if you have a longer endurance than 5 seconds, okay? And we're also trying to pay attention to, after you contract that muscle, do you feel the muscle relax? For some folks, they turn the muscle on and then the muscle, it takes its sweet, sweet time trying to relax, okay? And that can be a sign of pelvic floor muscle tension, pelvic floor coordination issues, a number of things, okay? So not just the strength is the concern, okay, but also the coordination. Speaking of coordination, let's talk about what I like to call the tapping your head, rubbing your belly, jumping on one foot of the pelvic floor, what we call quick flicks. So if this is your pelvic floor muscle fully relaxed, this is your pelvic floor muscle fully contracted, what I want you to try to do is a 25% of your range of motion, okay? Little pulses, little quick squeezes. Think of it almost like a snap or a pulse. So 1, 2, 3, 4, 5, and let go, okay? Remember how we talked about those endurance muscles versus those fast twitch muscles? Those little quick flicks are an example of fast twitch muscle training, or a way you can engage those fast twitch muscles in the pelvic floor. That longer hold is an example more of the endurance contraction, okay? So that's your first lesson of the pelvic floor, the difference between endurance, the difference between those quick flicks, okay? Now, when we're talking about pelvic floor muscle training, and I'll allude to this a little bit later, but just to kind of give you an example, okay? You can do pelvic floor muscle contractions in a lot of different ways. If you feel confident with what we just did, what I would typically do is progress you to doing the endurance holds and the quick flicks in standing. Can you do a pelvic floor muscle contraction with a squat? Can you do that while you're walking? Can you do that with stairs? Can you do that with jumping, right? Some people, I had someone who was specifically having leakage when they were doing a dig in volleyball. We brought a volleyball into the clinic and we worked on turning on the muscle, step, lunge, added the ball into the mix. So for that particular person, for her particular diagnosis, we made it functional for her concerns. And she was able to play volleyball and didn't have leakage, okay? Now again, like I said before, not if anyone with pelvic floor dysfunction, Kegels isn't necessarily the answer. For some folks it is, for some folks it isn't. Why it is so important to see a pelvic health specialist so they can help you create an appropriate program for your concern. So that is the quick and dirty of doing a Kegel, if you will. Okay, now there might be some of you who are sitting there going, yes, yes, I feel very confident in doing my Kegel. I feel really, really good about this. And really in your head, you're like, ma'am, I have no clue what you're doing. I have no clue what I'm doing. Please help me. That's okay too. That's a different baseline. That just reiterates the need that you might need a little bit of extra help to help with coordination, to help with isolation. Some of those folks, what I do with them, can we do a pelvic floor contraction laying on your back with pillows underneath your hips? So now gravity is helping you engage and let go of those muscles. Can you try it laying on your side or on hands and knees? That's a great way that you can play around with it. Some of these folks need more hands-on, intensive, additional assistance to help with that engagement, and that can be achieved with in-person physical therapy as well. So if you don't know what I'm talking about, it is not the end of the world, it's not the end of days. There are solutions. It's just about getting you the right person to help you with those. Okay, so we had our quick intensive of what the pelvic floor is, how to do a Kegel, all those different things. Now we're going to talk a little bit more about the sorts of conditions that a pelvic floor physical therapist can treat, okay? We are not going to get into specific treatment methods. You have this, I would do in order to address it. That's beyond the scope of this lecture, and unfortunately we don't have the time to dive into that today. But again, this lecture and today's presentation is for informational purposes only. The goal of this, if you will, is for you to be sitting and listening to this or watching this or wherever, however you're consuming this media, if you will, and say, you know what? I've had this concern for a while. Didn't really realize it was a pelvic floor issue. Now I know where to go to get assistance, okay? So this is not to diagnose anything. That's not my goal today, but just to you can seek help from the appropriate folks to get that accomplished, okay? So this is for educational purposes only. Please discuss this formally with your doctor before you try anything, okay? And again, this is only a sample of what sort of conditions a pelvic floor physical therapist can treat. As a pelvic floor PT, I always like to say, I'm kind of the island of misfit toys, right? What are the things in the pelvic, in the PT realm that your normal Joe Schmo physical therapy would be like, I don't know, go talk to your doctor about? We can take care of that. And that's why I love my specialty, because we can help so many people with so many challenging things that a lot of other physicians or a lot of other PTs will just sweep to the side and say, ain't my problem, go see someone else, okay? So that's my quick shout out to pelvic floor PTs being awesome. All right, so we'll start with urinary incontinence. So what does this look like, okay? The number of folks I've said, no, I don't have urinary incontinence. I only leak when I cough, laugh, sneeze, pick up my kid, or go running. I'm like, you have urinary incontinence because you leaked during all those different situations. So we can break up urinary incontinence into a couple of different realms, if you will, okay? One is what we call stress urinary incontinence. I cough, I laugh, I sneeze, I pick up my 15-pound cat, I pick up both of my 15-pound cats, and I have leakage as a result, okay? I do X, and then I have leakage as a result of that, okay? We can have urge urinary incontinence. Anyone who's been, holy moly, if I don't go to the bathroom right now, there is going to be a problem, right? That's urge urinary incontinence if you have leakage with that urgency, okay? If you have both, and unfortunately some folks can have both, stress incontinence and urge incontinence, we call that mixed urinary incontinence. It's kind of the umbrella term for both of those different terms, okay? You can also have a kind of incontinence called overflow incontinence, and you can see that more in neurological situations where the sensation of the bladder or the signal from the bladder saying, hey, I'm full, isn't there, and you can have leakage as a result of that. There's also a type of incontinence called functional incontinence, right? You have somebody who's having mobility issues and they can't necessarily make it to the bathroom in time, not necessarily because of a urinary concern, but because of a mobility concern. But that's still very much within the realm of a pelvic floor physical therapist to address. We can help those mobility concerns most of the time, right? So urinary incontinence is probably one of our most common reasons why we get referrals to pelvic floor physical therapy. Okay. Urgency of urination. Again, this is the, not just, oh my gosh, I feel like I'm leaking if I'm not going to make it there in time, but the, oh my gosh, I go to the bathroom 4 times an hour. I literally just peed and I have to go back and pee again. I feel like I'm living in the bathroom. Sometimes that can be related to urinary urgency or urgency of urination. Some folks with IC diagnosis or any other kind of diagnoses, there is a pelvic floor component to that too. So a pelvic floor PT can be essential in terms of that comprehensive treatment of those concerns. Okay, pelvic pressure or heaviness. Okay, I feel like there's a golf ball in my vagina, or I feel like every time I have a bowel movement, there's more there, even though I had a complete bowel movement. That can be related to prolapse concerns. And again, as I go through these, I do want to reiterate, these experiences that I have gone through, this is not just exclusive to females or males. Everybody under the sun can have these concerns, okay? So again, I don't want people to feel like this isn't for me. This isn't something I have to deal with, because again, I've seen male patients with prolapse concerns, right? I've seen everybody with urinary incontinence. So these are things that affect all people, and we want to be cognizant of that as we're discussing this. Okay, constipation. Does anyone know what that little white stool thing in the top corner is? Squatty potty, absolutely. Squatty potty, if you're looking for someone to sponsor, I volunteers tribute, please pick me, because I talk about the squatty potty all the time. And again, squatty potties are great ways that we can help with managing constipation, assisting with full emptying of the bowel or the bladder, because when you're in that optimal position with the squatty potty, it helps to lengthen the pelvic floor muscles so we can optimize emptying, which again is the goal and a great way to help manage constipation. And again, constipation is a bit of a finicky beast because it can present in a couple of different ways. But as a pelvic floor physical therapist, you can help with the muscles of the pelvic floor, with coordinating during bowel movements. You can help with assisting with motility of the colon by teaching an abdominal massage or doing visceral mobilizations. You can help with optimizing toileting positionings by using the squatty potty. So lots of things that we can do from the pelvic floor perspective to help with constipation. Pain during bowel movements would be another thing that we can assist with. Okay, pelvic pain is also an area that I think is a huge, important area of pelvic floor physical therapy that we can help with. And this can manifest in a lot of different ways. I know for me, I have some issues with tailbone pain. I can't sit during conferences or sit in the movie for that long without having to shift and move around because my tailbone hurts, right? That can be related to tension within the pelvic floor. Folks who have pain during intimacy, right? Pain with insertion, pain with erection, anything like that, that can be related to the pelvic floor. I have seen folks after having babies. I have seen folks after having vasectomies. I have seen folks after having numerous other surgeries have concerns with pain. And sometimes that can be muscle related. Sometimes that can be scar tissue related. Sometimes it can be both. But a pelvic floor physical therapist is a great person to talk to address those concerns. Obviously, with anything acute, go talk to a doctor initially. But once you get the clearance that everything's okay from that acute perspective, looking at pelvic floor physical therapy as an adjunct to help with pain management is essential. If anyone's ever heard of endometriosis before, right? What, 1 in 10 are diagnosed with endo, I believe is the stat here. And again, so many folks I've seen, I've been chasing a diagnosis for 7 years and didn't get a diagnosis until today, right? And pelvic floor physical therapy is a great way to help with pain management and the other concerns with endo. So again, if you know anyone with that concern, make sure they're seeing a pelvic floor physical therapy, or if you're having any of these other concerns, pelvic floor PT is the way to go. Okay. I think gender affirming care is another really important area to discuss, right? Because as pelvic floor physical therapists, we are optimally set up to help these folks with these sorts of interventions. Again, this is an area of the pelvic floor PT that I would recommend seeing a specialist in this. A general pelvic floor specialist might know some things, but there are folks who are even more apt to treat these sorts of patients with better success and making sure they're addressing things comprehensively. And we do have those folks in the Pittsburgh area, which is fantastic. So this is, we can address it from a number of ways, right? One, addressing pre-op concerns, right? The person might present with pelvic floor muscle tension or urinary concerns prior to the procedure. You can address things from a post-operative perspective, right? With a vaginoplasty, working on the appropriate use of dilation, things like that, working with any other kind of scar tissue concerns, right? So again, I think for these folks, the gold standard should be seeing a pelvic floor PT prior to any of these sorts of procedures and working with them after as well. And a lot of the physicians who are doing these sorts of procedures do have close relations with a pelvic floor PT or a physical therapist to make sure, all right, here's your pre-op appointment, you got your post-op appointments, we're helping you manage the entire journey that they're going through, which again is massively important, and it's great that we have folks who do that too. Okay, I mentioned working with kids, right? I always used to say at my old job, I worked with kids as young as 5 and as old as 95 and everybody in between, right? So from the pediatric perspective, you can see pelvic floor dysfunction in a number of ways. Kids who have pain with bowel movements, they're saying it hurts to poop. They can't have a bowel movement. Pelvic floor PT can sometimes help with that. You can also look at concerns with bedwetting, daytime incontinence. I know I've worked with a lot of athletes, high school athletes who are having, I had a young, maybe 15, 16-year-old boy who was having pelvic pain concerns. I've had teenage gals who had urinary incontinence in the marching band. Every time they were walking and playing their instrument, they had leakage. Both of them benefited from pelvic floor physical therapy. So again, pain, constipation, bowel leakage, in addition to leakage of urine, can be a concern. Bedwetting, all those things can fall underneath the realm of pelvic floor physical therapy. Just like working with folks who are managing gender affirming surgeries, usually people who do pediatrics are more of a specialist area. There are additional classes that you would take beyond kind of the baseline. So again, if anyone's looking for a PT in that realm, we do have them in Pittsburgh. Okay, post-op care. I already alluded to this a bit, but not just for dealing with C-section, which I will go on a little bit of a rant here. Anyone had an ACL surgery before, right? Or heard of someone who had an ACL surgery, and they get a packet kind of describing all of the things that they need to do before surgery and after surgery for 1 week, 2 week, 4 week, 6 week, 8 week, and everything is very, very specifically delineated. What happens to somebody who has a C-section? They go to their 6-week appointment. Oh yeah, how's your baby? Your baby's doing well. Okay, yeah, you sleeping? Yeah, good. Okay, awesome. Well, I mean, you're cleared. 6 weeks, just get back to exercise, and you'll be just fine. Good luck. This person had a massive abdominal surgery, and we are saying good luck. It's ridiculous. We can do so much better than that as a profession and as a healthcare unit in the United States. I'm getting snaps. Thank you. So again, pelvic floor PT is the route, okay? someone who is pregnant, seeing a pelvic floor PT during pregnancy, even if you're not having issues. I loved my patients who said, you know what, I do CrossFit, I want to keep on lifting, but I want to do it safely. Can you help me do that? Hell yes, I would love to do that. That's a great group of folks to work with, right? People who come in during pregnancy with pain, right? Can work with them as well. Now you're looking at the post-op end of things. If it's a C-section, obviously pelvic floor PT would be great, but vaginal deliveries as well. I know I kind of digressed a little bit into a pregnancy postpartum side of things, but bringing it back to the post-op care, again, prostatectomy is another underserved population, and especially with my job currently, I do work with a lot of folks prior to having the surgery and seeing them post-operatively as well. Because again, after these surgeries, having continence concerns for about a year can be common if nothing is done. But if we're doing pelvic floor PT, we can reduce that amount of leakage, the length of leakage, all those sorts of things. We can help them tremendously. So again, this should be standard practice, referring to pelvic floor PT with these sorts of procedures. Abdominoplasty as well, or any other sort of abdominal procedure. I've seen folks who've had whatever surgeries in the abdomen and they just continue to have pain or concerns about getting back to exercise after these surgeries. And as a pelvic floor PT, we are optimally suited to help these sorts of patients. And again, any sort of gynecological or urological surgery as well. Even if the incisions are wee little, right? That doesn't necessarily mean that you're not going to have any sort of concerns. So again, it doesn't matter if you have a massive incision, doesn't matter if you have tiny little incisions, a pelvic floor PT can help you with a lot of things if you're having concerns after the fact. Okay, so you might be sitting here in this lecture hall or online and saying, you know what? I should probably see a pelvic floor physical therapist. In Pittsburgh, we are incredibly lucky. We have a great wealth of knowledge of pelvic floor practitioners in the area. Some of our major healthcare systems like UPMC and AHN both have pelvic floor physical therapy programs. There are smaller local clinics that exist around the area. There's some clinics that will see people in your house, right? They'll come over to your house and do pelvic floor physical therapy if you feel more comfortable with doing that. And telehealth is also something that has become an option in recent years. Now, I will go on a little bit of a tangent on telehealth. I work in telehealth. I've been working in telehealth for 2 years. I've had so many people say, you do PT virtually? You do pelvic physical therapy virtually? How do you do that? Obviously, it's different than in person, right? But you can still have a lot of success with folks depending on the person, depending on the diagnosis. I think that is essential. As a telehealth physical therapist, I recognize what I can do, and I can do that really well. But I also recognize when they're patients who have more complex presentations, they need to see somebody in person, they need the hands-on. What I can do as a telehealth physician is say, you know what? Let me get you linked up with someone in the community. We'll touch base in 4 to 6 weeks. Let's talk about what you're doing. Let's make sure we're optimizing your home program. So when you're done in person, now you can transition back to me and we can make sure you're being consistent and you're able to master what you need to do to help your condition. That's the way telehealth should work, right? Recognizing the limitations, recognizing the strengths, and working as a unit so we can get these people set up for success. It is not about who can steal whoever patient. I want my patient to get better. And whatever the most appropriate and optimal means to get that done, that's the way that it needs to get done. So again, telehealth, we don't want to damn it or demonize it like I was saying before, but knowing its strengths, knowing its limitations, and knowing when someone needs to go see a clinician in person. That I think is the essential part. So it is not a replacement, it is an adjunct, it is something that can work really well for certain people in certain situations, but it's not for everybody, okay? But for the people who do it, and it works really well, they love it. It's fantastic. They can roll in 1 minute before their treatment. It's amazing, right? So definitely pros to telehealth and cons as well. So I know we are kind of running pretty close to time here, and I want to be cognizant about that. And we won't necessarily go through all of these myths. I have 2 myth slides on myths about the pelvic floor. But I don't know if anyone sees a myth up on the board that they would like to yell out and challenge if that's a myth or not. Anyone? Anyone? Bueller, go ahead. Yeah. 100%, right? Like what we alluded to earlier, so many people, and they come to me being like, well, it's 6 weeks and they said I should be better and just get back to exercise, but I can barely lift up my baby without having pain in my abdomen, right? They need to see a pelvic floor physical therapist. So absolutely. So again, if you know anybody who's pregnant, postpartum, C-section, spread the good word, right? Make sure they see a pelvic floor physical therapist. Anyone else? Any other myth that we want to bust up on the board? Ellen, I think I see you looking at a myth up there. But yeah, 100%. Again, we talked a little bit about this before, right? Having muscles that are really, really tight or really tense doesn't necessarily mean that they are more successful or better at functioning than others. Think about your bicep. If your bicep can only move from here to here, okay, that doesn't mean it's stronger. That means you have a contracture. That means that muscle is stuck, right? And you can only work in this area. We want our muscles to be strong and to move in an entire range, right, to optimize function. I think I see Amy looking up at another myth on the board. Amy, what was the one you wanted to address? That's a great point. People only leak if they have kids. Absolutely not, right? If you have kids, you can leak. If you have kids, you might not necessarily leak. You might not even be able to have kids and you can have leakage, right? You might be young or in your teens and 20s and have leakage. So again, babies are not the only thing that cause incontinence. So it's really important to recognize that leakage is common, but it's not necessarily normal. And there's definitely ways that we can address this, okay? So anyone else have any burning questions about the current myths we have on the board, or do you want to check out slide 2? That's a great question. How often are we told, right? Suck in your stomach, be really small, don't take up a lot of space, right? Especially as women. How often are we told that throughout our lives, right? And it goes back to the point of being really tense and being really tight doesn't necessarily mean the muscle is better or that it's functioning more optimally, okay? So remember when we talked about the core and the movement of the core. If those muscles are sucked in all the time and really, really tight, how are we supposed to breathe optimally in that situation, right? That's not necessarily going to work the way that we want it. So again, squeezing and tightening any sort of muscle all day, every single day maximally is not successful. How I always like to equate it is if you had someone who was doing a wall sit for an hour and then you ask them to go run a mile, their legs are going to be jello. They're not going to be able to run very well. So think of it like that whenever you have those sorts of concerns. All right, so our last little page of myths here. Anyone have any myths that they would like to bust? This is your myth busting opportunity for anyone who's watched Mythbusters. Does anyone watch that anymore? It's a great show. Yep. Pardon? Ah, yes, normal to leak when you get older. Again, common but not normal, right? Aging doesn't necessarily mean you're 100% going to have leakage. We know that there are changes in the muscles that happen with leakage. But again, just like how we can do strength and conditioning for the rest of our bodies to optimize mobility, you can do the same sorts of thing for your pelvic floor. Absolutely. How about this one? Stopping your pee midstream is a good way to practice Kegels. We talked about this. What's the answer? No, thumbs down. Absolutely, absolutely. All right, so let's pick one more question here. Men don't have pelvic floors or pelvic floor issues. True or false? False, right? We know everyone has a pelvic floor, okay? Or we little kids or adults, everyone in between have a pelvic floor. And when you have a pelvic floor, there's a risk of having pelvic floor dysfunction. All right, so let's wrap things up here, okay? So what are our final takeaways? The too long don't read, I think is what the youth say, the TLDR, if you will. So final takeaways here, okay? Everyone has a pelvic floor. And if you have a pelvic floor, you can present with pelvic floor dysfunction. Just because something is common doesn't mean it's normal, okay? Just because you're talking with your friends and everyone's talking about having leakage doesn't necessarily mean that that's the way it is anymore, right? Common does not mean it's normal. Find a pelvic health specialist. Any physical therapist is not a pelvic health specialist, okay? Just like how any physical therapist isn't a pediatric specialist or a neurological specialist. This is a special area of practice that takes extensive time and training. If your person took a weekend course and says they are a specialist, then they are mistaken, because there's a lot more to it than a weekend course, and you want to make sure you're seeing someone who knows their stuff so you get the best care that you deserve. So please keep that in mind. That's something I'm very, very fired up about. Okay. Thank you. Again, I know this is, I could talk forever, but I kept you captive for 50 whole minutes here. But I really appreciate everybody coming out tonight to learn about the pelvic floor. And I hope you're leaving here with just more information and more of an understanding of your pelvic floor. And again, if you're having any concerns, knowing that, you know what, there is an opportunity where I can get help. I'm going to talk to my doctor. I'm going to see if this is appropriate for me. And if it is, I know I've got resources here in Pittsburgh that I can get my care taken care of here. Okay. And again, just a quick shout out. I know I mentioned earlier my podcast. That is a very casual, very fun podcast, Plot Holes and Purrs. It's on Spotify. So again, if anyone's interested in fantasy novels and wants to hear about it from a very casual way, I reiterate it is very casual. that is a great way. You can learn about that and listen to me yap. If you enjoyed the bad jokes that I made and the horrible puns, you can get more of them on the podcast. But thank you all so much for your time. I really appreciate you coming out tonight. And I think we are shifting over to questions and answers.
Yes, we are. First of all, I'd like to thank you, Dr. Emily Earnest, for doing this talk tonight. It was absolutely fantastic. And we are going to go to questions. We're going to try to go back and forth between audience questions and the questions from our live stream. So we're going to go ahead and jump to the live stream for our first question or two, and then we're going to go to our audience for the next few questions as we are good to go. So our first question we have on here, we have from Kitty Mama. How did you become interested in pelvic floor physical therapy? I appreciate your enthusiasm.
I think that might be my mom, cat mom. I'm not sure. But how did I become interested in pelvic floor physical therapy? Great question. Thank you. So my first job out of PT school was at McGee. But I do remember this was anatomy, my first year of physical therapy school. And the women's health resident at the time came in and did a lecture about pelvic health. And I remember her talking and me being like, yeah, that actually sounds really cool. That sounds awesome. I don't know if I'd be good at that. I just never pursued it. So when I was at McGee, I had the opportunity to shadow actually, who's now one of my best friends and is also a pelvic floor physical therapist. And I shadowed her, ended up switching to that department, getting trained, and I've been working in pelvic health ever since. And the reason I got into this specialty, and I used to work in acute care again at McGee, and I loved working in acute care, right? That's definitely something that I enjoyed. But being able to help folks in very difficult situations who have sometimes seen doctors and specialists and all these different people, and they come to you and they are desperate for help and they don't know what else to do. This is ruining my marriage because I'm having pain during sex. I stopped running because I'm leaking when I'm running, right? There's some really debilitating things that these people are suffering with. And knowing that as a specialist, I have the capacity to help them. And again, I remember a patient in particular who was having pain with intimacy, and her and her spouse wanted to have a kid so badly. And I remember it was maybe a week after I discharged her, she called and said they're pregnant, right? So they achieved that goal, which is tremendous. So knowing that with PT, they were able to start that goal as a family was awesome, right? Having people say, I was able to run this race and I didn't have leakage and I enjoyed myself. That's why you do it, you know? So again, I'm very passionate about this specialty, and being able to help folks in those situations is why.
We have a two-part question here from Robin Hossman on our live stream. Part one is, does a physician need to write a prescription for pelvic physical therapy? And is pelvic floor physical therapy helpful for difficulty completely emptying the urinary bladder during voiding?
Yes, great question. So in the state of Pennsylvania, and again, I'm licensed in Pennsylvania. I'm not licensed in other states, so I can't speak for other states if we do have listeners from out of state. In the state of Pennsylvania, we do have something called direct access. So as a physical therapist, if you're practicing, I believe, for over 2 years, you are able to apply for something called a direct access license. With that license, you as a patient can call the clinic and say, hello, I'm looking for a pelvic floor physical therapist. I do not have a script from my physician. If they have a practitioner who has direct access, then you are able to see them for up to 30 days without a script from a physician. So what happens is the physical therapist would evaluate you. They have the plan of care. That gets sent to the physician. The physician would sign off if they agree. Then you'd be good to go from there. For the concern that you mentioned, if you have difficulty with completely emptying your bladder, again, I don't want to make any kind of broad diagnostic claims here, but sometimes you can see folks who have difficulty with completely emptying their bladder, or that sensation of being able to incompletely empty their bladder when they have pelvic floor muscle tension, right? Think about the need of the pelvic floor to lengthen, to elongate with voiding. If there is pelvic floor hypertonicity, sometimes that can be a culprit in contributing to those symptoms. So again, I urge you to talk to your doctor about that. And again, if they're on board and they agree with that, that might be something you can explore to help with your symptoms. I think that got both of the parts.
All right, so we're going to go to our audience. If you raise your hand if you have any questions, and just a reminder, when you are talking into the microphone, please hold it up in front of your mouth and speak just over it. Don't eat it and don't hold it too low, please. Thank you.
How soon after childbirth, typically, not, anything specific, but how soon after childbirth do you typically see people
see patients?
ready for,
100%. So typically, again, it's that magic 6-week mark that doctors often give to patients that say, oh, yep, after 6 weeks, then you can go see a pelvic floor PT. That 6-week magic mark is typically what we also say in the pelvic floor world is no intrapelvic work until you hit that 6-week mark. So if someone had a baby, you can't do any of the internal work with the patient if that's, again, appropriate for their concern, which usually postpartum it is, until that 6-week mark. However, right, postpartum, you're 2 weeks, I'm having severe SI pain, I can barely walk around, you'd be very appropriate to go see a PT sooner, right? So again, that 6-week mark is usually something that exists in the world that, oh, no, can't see them until 6 weeks. You can see them prior to that, especially if you're also having concerns. What we don't want to do prior to that 6 weeks is jump into things too aggressively, right? Intrapelvic work would be too much to do unless there's a warranted situation to dive into that and there's explicit clearance from the physician. But again, in that 6-week window, you can still talk about, hey, here's your plan to get you to return to running. How do we start you off with that, right? Are you having any mobility concerns? Are you having upper back pain from breastfeeding? Can we optimize your positioning? So there's a lot of things that you can do prior to that. So as we like to say, it depends, right? So, so standard usually is that 6 weeks-ish, but if you're having any other concerns, any other concerns, you can certainly go in sooner to get that addressed. If we need to kind of edit anything, get clearance from your doctor, and you're usually good to go. Good question, though. Thank you, Alan.
To follow that one up, we have a question from the online audience. It says, my doctor has referred me for a pelvic physical therapist visit. How can I prepare for an effective visit?
That's a great question. So with pelvic floor physical therapy, I'm going to make the assumption that this person is coming in for an in-person visit. I think the key things to know is like what's to expect with an in-person physical therapy visit. And obviously that's slightly different than a telehealth visit. So what I would prepare in advance, right? And I always like to do this when I go to doctor's appointments, right? Make a list of your concerns, write things down, because in person or in the moment, you might forget some of your concerns, right, when you're sitting there with the clinician. I recommend filling out your paperwork in advance if you have that option too, because that can also help to spike your brain in terms of thinking of the things that you need to be aware of. List of medications, those sorts of things as well. I think the other thing that is helpful for folks to know or have an understanding of is what an in-person physical therapy visit looks like, right? Key looks different for everybody, okay? Just because you're going to a pelvic floor assessment doesn't necessarily mean that, you're gonna have an intrapelvic examination. I've used that expression a couple of times, intrapelvic, so I'm gonna define that here. So traditionally with pelvic floor PT, okay, one of our specialties and the things that we do is the ability to assess the pelvic floor muscles, right? So we have different ways that we can access that, okay? If you have a patient, again, all this is done consensually. This is only done if a patient feels comfortable with it. It's only done if it's indicated, okay? So that's very important that needs to be clarified prior to the fact. But you can assess the pelvic floor muscles, again, if the patient is undressed, usually from the waist down. They usually have a sheet or something over their laps. Again, all this after you explain and talk about it with your clinician. You can assess the pelvic floor muscles externally, right? You can actually feel for the muscles kind of around the vaginal opening, again, or around the kind of the base of the penis, again, around the anus as well, okay? In addition, you can also do an internal exam. So that can be an intravaginal assessment, okay, or that can be an interrectal assessment. Typically how that goes for an intravaginal assessment, okay? 1 to 2 lubricated digits inserted intravaginally so that you're able to palpate, as in feel, the muscles in the pelvic floor, okay? If you're doing an interrectal assessment, that's usually a single digit, again, lubricated, you can palpate the same muscles, okay? So the goal with that assessment, what would we do with that? How is that different than what we just discussed here a moment ago, okay? What information you can gain from the internal assessment is knowing definitively pelvic floor muscle tone. Are they hypotonic? Is it that trampoline that's kind of really, really elongated and doesn't have a lot of tension, okay? Is it a pelvic floor that's really, really tense? Think about the knots that you can have up on your shoulder. You can feel that in the pelvic floor muscles as well. You can have elevated tone in the pelvic floor. With the pelvic floor muscle strength, you can also quantify their strength, right? We have a scale that we use from 0 to 5 that you can quantify the quality of the contraction. You can give a definitive definition of what their endurance is, of their quick flick, all those sorts of things. So there's a specific pelvic floor assessment that you would do, and that for that information, you can determine your plan of care from there. Now, I just said that, and sometimes I have that exact conversations when I worked in person with patients, and some of them would look at me like this, like horrified. Do you know what that means? Pelvic floor internal assessments, not a fit for you. And that's okay. And I tell them it is part of the puzzle that we can use, but it's not something that we have to do. And again, I see folks telehealth. We don't do any of the internal assessment there, right? Again, that's helpful information to have. It can help with creating a plan of care, but you can still really, really help folks without doing those hands-on things. So any clinician who would say, oh, well, I can't see you, don't let me do an internal assessment. Nah, you got to find a different clinician, because there's a way, right? And the number one way of treating folks is the way that makes them feel most comfortable. Okay, that's priority number one, right? I could have all the tools in the toolbox, and if you're like, nope, that's not happening, that's fine, right? We find a way that works. Okay, so bring it back to the question, right? What to expect with the pelvic floor physical therapy appointment, or how to prepare. List of your concerns, list of your medications. Know that your pelvic floor clinician might have a conversation with you or ask, are you comfortable with doing an intrapelvic exam? And knowing that you as a patient have a right to say, yes, I feel comfortable with this, or no, I don't. You have a right as a patient, if you start the exam and then you change your mind, you're already changed and on the table, you can say, you know what, I'm done, that's not happening, that's okay. I think if I'm gonna impart anything on anybody, I think as a patient, I don't care if I've seen you once or I've seen you 100 times, you always have the right to change your mind, and you always have the right to say, not today. I know I had patients who used to make fun of me because every time I asked, I was like, are you okay with doing this? And they're like, oh my God, we've done this like 40 times. And I'm like, I will ask you every single time because it's that important. So I believe that answered your question. Also realize I'm carrying around my pelvis like a baby.
Again, if anybody in the audience has a question, please raise your hand. We'll do two from the audience here quickly.
Question on the other side. So incontinence in someone who has dementia, do you work with those types of patients also? Is there challenges that go with that that are significantly different than other patients?
Yeah, that's a great question. I think the biggest concern with folks with dementia is it's less of a, I'm coaching you on Kegels, because again, from the cognitive perspective, they might not necessarily be able to grasp that. But typically with those patients, the education provided can be more in regards to timed voiding. How often is the caregiver helping the patient get to the restroom, right? Optimizing toileting habits, avoiding bladder irritants, things like that. That's more of the side of things that we can help folks with. So again, it's possible you can get benefits from it, but it tends to be more caregiver education rather than direct education for the patient itself. But again, variable depending on the severity. Because again, if that patient, you can talk them through how to do a Kegel. You palpate the Kegel. They're comfortable with that. You as a caregiver or as a child or whoever's taking care of this person can say, all right, let's do these together. Then that's a different situation, right? You can get some more success with that. So it's very dependent on the patient, but the answer is yes, just variability of success depending on their cognitive status and the amount of help available is what I would say. Does that answer your question?
Yeah.
Yeah, okay, thank you.
Hi, I have two quick questions.
Please.
One is like, what are the average number of sessions that someone needs? I'm sure it varies depending on their condition. And in terms of pediatrics, like, do you recommend, I'm a general pediatrician, do you recommend like most kids who have toileting issues check in with pelvic physical therapy? And I'm guessing they have that at Children's Hospital.
So great question. So I'll answer the pediatric one first. So Children's Hospital itself doesn't have a pelvic floor physical therapy, but in UPMC, any of their pelvic floor physical therapists should be trained in pediatrics. So all those should take referrals. Another clinic specifically that I know they're specialists in pediatric, because I used to work there and they're fantastic. We just moved to the North Hills. So Restorations Physical Therapy in Upper St. Clair, they have some fantastic physical therapists down there who are pediatric specialists, so that would be a great place to make referrals too. But again, I know the UPMC folks are certified or trained in that as well. I can't necessarily speak for AHN in its entirety because I never worked there, but I do know they've got some great practitioners too. In terms of the length of visit, again, very dependent on the diagnosis, but typically for plans of care, it's usually once a week, once every other week for 6 to 8 weeks, or pardon me, 8 to 12 weeks, and then you kind of reassess at that time. So I would normally say between 6 to 10 visits is usually for an average person. Like if you're looking at like stress urinary incontinence, something like that, folks with pelvic pain and endometriosis, that's a bit more of a complicated bear. That can usually take a bit more time. So those plan of cares can be longer, and those plans of care can also be more frequent. Sometimes people come in for tune-ups like once a year, things like that. So does that answer your question? Okay, perfect.
We're going to come back. We're going to go back to our online audience here. Questions? First question. Is there a relationship between pelvic floor issues and anal fissures? Do they often go hand in hand? How do you treat them?
Yeah. So again, that kind of comes back to the pelvic floor muscle tension, right? If you have somebody, so again, not the entire picture, but part of the picture. So if you have a person with pelvic floor muscle tension, they can't relax their pelvic floor muscles. Now they also have bad bear down mechanics for trying to have bowel movements. They're pushing and straining. They also have concerns with stool consistency and stool quality. So they're pushing and straining even more. All those factors could contribute to anal fissures or pain with bowel movements or anything like that. So again, I think obviously number one, talk to your doctor, make sure that you're addressing things from a dietary perspective. If you need stool softeners, things like that, that would be thing number one. But if this is a persistent issue that you're having problems with, pelvic floor physical therapy could be something that you could look at. That I've seen folks in the past for those concerns or pain with bowel movements, and that's been beneficial. So
I apologize. I might say this incorrectly, but you can correct me. How can I distinguish between incontinence and cauda equina syndrome?
Cauda equina syndrome, yeah. So cauda equina syndrome is a medical emergency, okay? So if you are having numbness in the groin, you can't feel anything, you're having complete loss of bowel and bladder that is completely uncontrollable, that's more of a sign of cauda equina. You have to go to the emergency room now, okay? So if you've had it for a while, you have to get checked out, because that's something you can't dilly-dally with. Regular urinary incontinence usually it's associated with that urge, right? If I don't go right now, I'm going to have leakage, or it's associated with that cough, laugh, sneeze, or something like that. Unless you've had a neurological concern. If you've had a fall or you've had no neurological issues and we know that you have a neurogenic bladder, again, that could be more related to that overflow incontinence. So again, cauda equina is a medical emergency. You would have gross loss of bowel and bladder. That's the kind of the giveaway factor with that, and you need to get checked out immediately. The other sorts of incontinence, it wouldn't be constant leakage. And again, it can be variable in terms of frequency, intensity, those sorts of things. So please go get checked out if you have concerns for cauda equina syndrome.
We're going to go back to our live audience here. Raise your hand if you have any questions. All right, we'll return to our Zoom audience. Would a pelvic floor physical therapy help with SIJ pain?
It depends, right? So let's talk about it, okay? So SIJ, right? Sacroiliac joint, okay? So typically when we're looking at the SI joint, okay? A lot of times those will get referred to your general ortho, okay? So if you've seen orthopedic physical therapists before, it's not quite doing the trick, then you might benefit from seeing a pelvic floor physical therapist. And why do I say that, okay? I'm thinking back to a patient that I ended up seeing at one of my previous places of employment that one of my orthopedic colleagues was seeing them for SI pain. And they're like, oh my gosh, I can't get through with this patient. I have no idea what's going on. I can't help them. I was like, let me talk to them. Let me see. This person also had urinary issues. This person also had tailbone pain. Turns out they also had pelvic floor dysfunction. So sometimes with these certain orthopedic presentations, right, unspecified hip pain that you can't necessarily get to, you've done imaging, your labrum's fine, you've seen your hip specialist, and it could be OI pain, obturator internus pain, right? That's a pelvic floor issue. So for this person with SI concerns, could be a chance, but sometimes you can see that with these other symptoms. So if you're having those other urinary symptoms or other concerns like that, then it might be worthwhile to have a conversation with them. Pelvic floor PTs just look at things through a slightly different lens, okay? We have that general PT lens, but also a special set of glasses from the pelvic floor people.
Another question. Do vaginal barbells improve pelvic floor health or are they total nonsense?
So the evidence on vaginal weights, okay, is not necessarily best practice in terms of optimizing pelvic floor muscle strength. So what we mean by that is there are devices that you would insert intravaginally, like a tampon, okay, that has weights on that. You can do Kegels and lift and pull those weights up and down, almost like a barbell, okay? Evidence perspective says that's not necessarily best practice. What we say is best practice for doing Kegels is functional strengthening, right? Remember my volleyball gal, right? That's a functional strengthening task. There's a lot of different variations of ways you can do that. And the theory behind that is a pelvic floor muscle, you're never physically lifting anything up. So that's not necessarily the best way to strengthen it. The other issue with those is one, they're inconvenient, I'll say, in terms of they're not necessarily easy to incorporate into your day-to-day routine. So compliance wouldn't necessarily be there. You're also limited in terms of the positions that you can do those in, okay? Can't really do them lying down, you know, so you're kind of in a standing position and that's the only way that you can do them in. So again, I would say if you're looking for ways to optimize your pelvic floor health, talk to a pelvic floor physical therapist. I would spend your money on other things like fun holiday sweaters.
Do we have any more questions from the audience?
Thank you. I thought of this particularly because somebody over here said that they were a general pediatrics doctor. Anyways, what level of knowledge, education would you say that there is generally amongst pediatricians around the fact that children can and sometimes should be referred for pelvic floor therapy?
That's a great question. So I think just like in the adult realm, there's room for opportunity, right? And I think it's challenging because even when you're looking at folks postpartum, right? Like we have hospitals here that have maternity wards, right? And do we have a pelvic floor PT talking to every single one of our patients? No, absolutely not, right? And again, from the pediatric side of things, I think it's physicians are trained through a different lens, right? I was trained through a PT lens, so I look at things a little bit differently. So I think pelvic floor PT is still coming on the radar for not just pediatricians, but also for your GPs, also for folks who are in urology, right? And in gynecology as well. So I think overall, as a society and a world, we need to have a better awareness of pelvic health. But I think for the pediatricians who do find out about pelvic floor PTs, they're like, yes, this is awesome, because they see the success that their patients have. And it's fantastic. So I know when I worked in that realm, we would get specific physicians who would refer for X condition, Y condition, because they knew my person has this, I send them to Emily, they're going to be smooth sailing, right? So once they have that rapport, that definitely kind of was solidified, and they took advantage of that over time for sure. So good question.
Going back to our online audience, can you please discuss all of the serious complications for the pelvic floor during and after gender-affirming surgery?
Right. So that is a bit of a broad question that I don't necessarily know if we have the time to kind of go into in depth with that. But again, what I would encourage you to do is if that is something that you are undergoing, and I'm so happy that you're going through that, if that is something that you are doing, is talk to your physician who you are looking at having that surgery with and see if they have a pelvic floor physical therapist that they can refer you to, that they already have a rapport with. Because a lot of times those physical therapists will have the specific protocol that they like to follow depending on what intervention is being done. So that's what I would say the first step is. If they don't, then I would highly recommend, okay, now I need to try to find a physical therapist who would be able to help me with that, who is a specialist in that area. So pelvic health physical therapist at minimum, but ideally somebody who works specifically with folks who are transgender. I can't necessarily dive into I'm trying to remember the exact phrasing of the question, but what are the complications that could go wrong with that? But I think the big things to be mindful of for any post-op scenario, right, is wound dehiscence, right? If wounds or the incisions are tearing apart, right, and pain and bleeding, those sorts of things. So general post-operative things. But again, your doctor will talk to you about those very in depth after the fact. But again, pelvic floor PT can help from the scar mobilization, those sorts of things afterwards. So I'm sorry if that's a bit of a vague question, but I want to make sure you get an in-depth answer, and I don't think this is necessarily the platform to do that on right now, but please seek further guidance from your physician and another pelvic floor PT.
First off, this proves once again that I always come to Cafe Sci regardless of the topic, because this topic that strikes me as the strangest is often the most informative. So I was wondering, I've known a few people who have had prostate surgery, and then they've talked about having problems with leakage and things there. Is that just because, well, not just because, but how does that relate to pelvic floor issues? And is that something you've dealt with, and can you help people like that?
Oh yeah, so absolute great question. So, and I'm so happy that you're like, oh, this was a little bit bizarre, but I've learned things, so that's fantastic. So with prostatectomies, right? And again, there's a lot of different types of surgeries you can have for prostate cancer, but just we'll speak very broadly and very generally. So if the prostate is removed, you lose some of the structural support that you have in that anatomy, right? So without that structural support, that's one of the reasons, in addition to just the surgical interventions itself, folks can be at risk for leakage. So anytime you have surgery, right, the muscles, and again, I'm grossly oversimplifying it, but the muscles in the region are a bit like, whoa, like what the hell's going on here? They're trying to figure it back out. So in addition, from that coordination perspective and scar tissue restrictions, if there are any sensitivities from the incisions, from the muscle coordination strength perspective, absolutely get benefit of that. I actually had a patient fairly recently who he was seeing one of my colleagues in the neuro clinic, and he recently had prostate cancer and had a prostatectomy, and he had no idea that pelvic floor physical therapy was a thing. And his big thing, he had a golf weekend that he wanted to prepare for, and he was like, I want to be ready for this golf weekend. And then my colleague referred him to me. He was golfing and he didn't have to worry, you know, and he had such success because his leakage was so much reduced from when we started. So that population, in my dream world, I'd love to see them preoperatively so we can get a baseline strength. They know exactly what a pelvic floor muscle contraction is. We can make sure they're set up for everything postoperatively. And then when we see them postoperatively, they get the clearance from the doctor. Now we get them on the program. So you're going to have leakage after those surgeries. It's inevitable. But what can be changed is the volume, the frequency, and the duration. So all of those things can be helped with pelvic floor physical therapy. I think it's a great patient population to work with. I enjoy working with those folks. So does that answer your question?
Oh, yeah.
Yep, excellent, good.
We're going to go to one more question in our audience.
Hi, since you worked at McGee, or I guess you could work at other places, did you have any interaction with doulas, or is there like a place that they could get some information to inform their clients that have C-sections that they shouldn't feel normal after 6 weeks if they don't?
Yeah, great question. I know when I was working at UPMC, and names are escaping me, and I apologize for that, but I did work with some doulas and midwives from the Midwife Center in the Strip, and they were delightful, fantastic folks. So again, I have worked with those folks in the past. I can't necessarily give names, but I do think that, I mean, everything that center does is pretty darn fantastic. So I think everybody kind of underneath that umbrella would be a good go-to. But again, I've worked with, I mean, I've had patients in the past who were doulas who came to me as a pelvic floor physical therapist. I've had folks who also have a doula on board, and we've collaborated together. So I'm all about I don't know if anyone likes Marvel and the Avengers and things like that, but like assembling the Avengers, right? Getting the whole team together. So I love interprofessional care. So I think PTs and doulas and midwives definitely have a great ability to collaborate, and that's something that should be taken advantage of. Does that answer your question? That's okay, perfect, thanks.
All right. As we wrap up, we're going to ask one fun question here, and I'll follow up with one for myself. Since you write fantasy novels, have you joined Parsec or SFWA?
I haven't. It's on my radar though. It's on the to-do list right now. Again, I don't want to digress too much from my my pelvic floor lecture here, but I'm currently in the querying stages of my well, one for my fantasy novel and two for my horror romance novel that is actually based in Pittsburgh. So I'm looking at getting those hopefully published sometime in my lifetime, I'll say. But no, I have not joined those, but I think that would be on my radar sometimes in the future.
And to add on to what you just said there, is any of your writings online or in print that our guests here could follow up or look for?
Oh, that's very kind. I appreciate that. No, right now it lives in my Google Drive. So if you're able to hack into my computer, you can access it at your free will. Please don't do that. That would not be great. No. I have not. I've also published, or not published, but written some several short stories that I've currently in the works. I submitted them, so hopefully maybe I'll be successful in a contest or so. But at some point in my life, I will make a website and we'll have these writing things available. But I do not have that quite yet. But I appreciate you asking.
Well, we'd like to thank you for being here, and we'd definitely love to have you get a round of applause from our audience.
Thank you, everyone. Thank you.
I'd like to thank everybody who joins us online and in person. And again, join us next month for Cafe Sci.
Thank you, everybody. I appreciate it.